Hi, listeners.
Hello. Welcome to the Med Insights Unleashed podcast.
With your hosts,
Z.
and John.
Hi, John. Good morning. How are you?
Hi, Z. How are you? Thank you for all your help at ASCO, where we met our host. It's coming on today to talk to us, which is really great.
Yes, Ask was great, super busy. You and I were just working it. And you're right, we're fortunate enough to have Professor Escudier in the studio. Professor, did you want to?
Introduce yourself.
Happy to be here today. I am Dr. Escudier. I'm working in Gustave Roussy, which is a big cancer center in Paris. And they have been leading the kidney program for more than 30 years now. So I've been involved in kidney cancer treatment from the initial development of interleukin-2 up to the new targeted agents and immunotherapy up to date. So I'm very happy to be with you today.
On behalf of all the patients, thank you for all the research that you're doing to advance survival rates in renal cell carcinoma, Professor Escudier.
Yeah.
Professor Escudier, the Keynote 564 was a study with pembrolizumab being used in the adjuvant setting, was a positive trial and the first positive trial in adjuvant renal cell carcinomas. While we're talking about first line, I would really like to know how this trial impacts decisions on the first line treatment.
So when you speak about metastatic kidney cancer, you should remember that probably half of the patients are metastatic upfront, which means that at the time of the disease discovery, I mean, they already have metastasis, and half of them become metastatic after initial surgery. And this is the patient we are talking about. I mean, some of these patients have high risk of relapse, and we know that for many years. And we have tried, of course, many treatments to try to decrease the risk of recurrence and to improve survival in those patients. So we have tried a lot of treatments. Initially, we have tried targeted therapy like VEGF inhibitors, sunitinib, sorafenib, etc., etc. All of these trials have been globally negative. Then we tried immunotherapy because it makes a lot of sense to try immunotherapy. And interestingly, only one of these trials has been positive, which is the one with pembrolizumab, giving as adjuvant therapy for 1 year. And this trial showed that one, we delay disease recurrence, and second, ultimately, we improve overall survival. Based on that, it's now become a standard of care to give adjuvant therapy in high-risk RCC, clear cell RCC, after surgery, which means that high-grade large tumors, and we are not going to go into the details of the indications, but globally, high-risk patients are large tumor with high-grade tumors. So the question now, if you relapse after adjuvant therapy, because probably some of these patients are going to relapse, unfortunately, after adjuvant therapy, is it going to change our first-line treatment? And certainly it's going to do, because if we relapse during pembrolizumab or very shortly after pembrolizumab, it probably means that you have kind of refractory disease to immunotherapy, and it's going to change the way we are going to first-line treatment here.
Can I ask a question with regards to the high risk, just so that the listeners are aware? Is there a cutoff in terms of the tumor size? Like when you say large tumors, what is your size? Is it greater than 5 centimeters or?
And when you speak about high risk, you speak about what has been the initial classification. And when you speak about T3 and T4 tumors, which are the tumors where we speak about adjuvant therapy, usually most of these tumors are more than 7, 5, or 10 centimeters. Also, some of these tumors are not very large, but are very extensive outside of the kidney or involving the venal cava or so on. So it's mostly large tumor, but sometimes it's not very large tumor, but very aggressive tumor in terms of invasion of the organs surrounding the kidney.
There is several different combinations now available to you. How do you choose which of these combination therapies for a specific patient?
I think we have to to remind people that kidney cancer is a very heterogeneous disease. Actually, we try to classify our patients based on what we call prognostic factors. And we have been working on that question for many years. And now we have good way to classify patients into good risk, intermediate risk, or poor risk patients, which just means that overall, in terms of statistic, and it's never exact for individual patients. If you have a good risk disease, it means that your expected survival is going to be more than 5 years. If you have a poor risk disease, it's still actually, even with our new treatment, probably going to be less than 1 year. So of course, our way to select treatment we are going to deliver to patients is going to depend on this classification between good risk, intermediate, and poor risk. And interestingly enough, if you go to good risk patients, some of these good risk patients have a very indolent disease. And you have to remember that in some cases, we are going to wait and do what we call surveillance because metastases are going to be very, very slow growing disease. And I have some of my patients who have never been treated, despite the fact that they have metastatic disease for years and years. And you have always to remember that important part of the treatment paradigm in kidney cancer. But let's go now to patients who need treatment, and usually that's patients with symptoms or with a large tumor burden or with a lot of metastasis inside the body. In this situation, the way we are going to select the treatment is probably going to depend on what we have been doing in terms of clinical trials. And interestingly, we actually have 4 different regimens which have proved in, I would say, in Europe, in the US, which are based on a combination of immunotherapy to either VEGF targeted agents or a second immunotherapy. And that's interesting that we don't have any head-to-head comparison study looking at one versus the other regimen. All these regimens have been tested and approved in comparison with a single monotherapy agent, which used to be our standard of care in the past. We have actually 4 treatments that we can use. And honestly, we don't have absolutely clear way to select between one of the other treatment. We have some trend and also some, I would say, habits, depending on the country you are in, depending on your experience you have. But there is no clear-cut data, which is, this patient should receive this combination or this patient should receive this combination. We just have some trend and some ideas to help us to select.
So I think as part of your, or help me understand, as part of your selection criteria, that patient that's sitting in front of you, they would also ask you the question around quality of life and side effects, right? Because that would be a big component in terms of your decision-making process. Can you kind of further elaborate on what that conversation would look like, or how do you make that decision with the patient?
The first question patient asks us is not quality of life, is can I be cured and what's the best way to be cured? So that's actually the first question that the patients have, especially in first line. They still expect to be cured.
Sure.
And we always explain to the patients, we have a chance to cure you, although it's not very large, but we actually probably cure between 10 and 15% of our patients. When I mean cure, it's at least 10 years control of the disease. We don't have, 20 or 30 years follow-up, but actually we probably cure between 10 and 15% of our patients. It means it's not zero, it's not 50 or 60%. So it's in between. And of course, we still have to say, patient, we can cure you. And when you say we can cure you, they just want to say which is the best treatment. They never ask us first question, that's what's going to be my quality of life. They ask us second question, what's going to be the side effects, but they never ask quality of life. They ask about side effects and how they are going to impact the way they are going to live.
Professor Escudier, you mentioned cure, which is the CR rate, complete response for the patients. Several of the trials have different complete response rates. Is that a factor in the decision that you make, the one that has the highest complete response rate, or is it based on the prognostic factors associated with that patient sitting in front of you?
Well, one of the problems about complete remission rate, which is reported into the study, is that the definition of complete remission is not my definition of complete remission. My definition of complete remission means that there is no disease visible. The definition by what we call the standard RECIST criteria, which is what we use in oncology actually, is based on non-measurable small disease, which in many situations, I know that they are not cured. When I speak about cured, I speak about not only complete remission, but I speak about complete remission lasting for more than 5 years after we stop treatment. That's for me at least a good sign that these are really complete remission here. Complete remission is for me the main goal we have to look at, because to cure patients, we have to go through complete remission, whatever the definition is. We have to go to no left disease and patient being out of treatment going well. Yes, of course. I mean, if one treatment give more chance to cure patients, I'm going to be more excited to use it than if a treatment is not going to cure patients in the same level and same incidence. Of course.
At ASCO, there were several publications on biomarkers from the frontline setting. One where Victor Grunwald was presenting the data on his study. How do you assess the role of biomarkers in that decision process?
To be fully honest, at that point, we don't have reliable biomarkers to select one versus another treatment options. We mostly use clinical and pathological biomarkers to help us to select. As an example, some tumors look more angiogenic, which means that they are slow growing. We have a lot of vascularization into the tumor. And we believe that these patients have more chance to respond to VEGF-targeted agents. Some tumors are more inflamed with a lot of inflammation, a lot of signs that these tumors are more sensitive to immunotherapy than they are going to be to VEGF-targeted agents. As an example, in sarcomatoid tumors, when it happens, are more likely to respond to immunotherapy-based regimen here. So we actually base our decision mostly on grade, on clinical profile, but not yet on biomarkers, although it would be ideal to have these biomarkers. So at this ASCO, we had some presentation, but all of these presentations were done looking at biomarker versus sunitinib, which is what we have as control arm. What we want to have is biomarkers versus, let's say, pembrolizumab plus lenvatinib versus nivolumab plus cabozantinib, which are two active and approved regimens. Is it any biomarker which is going to help us to select between one or the other one? And either in the same way, I mean, can we select between IO, which is combination of two immunotherapy versus a combination of IO and VEGF, and we still don't have this biomarker. I have the personal opinion that PDL1 is an important biomarker to help us to select between IO and IO-TKI. Because when you look at the IO data, which have been reported a long time ago now, those patients who benefit the more from IO are those patients with PDL1 positive disease, which is not the case with IO-TKI combination. In IO-TKI combination, PDL1 status has no obvious influence on the treatment outcome. In IO, it's different here. And we have launched a big study in Europe looking at this PDL1 expression to help us to select between one versus another one treatment. And this study has just started in Europe and it's called CARE1, and I hope it will answer some of the questions we have today.
And funny, John, that you asked that question, because I was actually thinking the same question around biomarkers. A follow-up to your biomarker question for Professor Escudier is around blood screening proteins. Is there utilization of kind of a blood screening protein, which is an easier test, right, than having to conduct RNA sequencing or DNA sequencing for patients?
So, of course, I mean, having proteins in the blood or cells in the blood, which would be useful to help us to select, would be absolutely ideal. At ASCO this year, we had some interesting data about KIM1, which is a molecule which we have known for a few years now, but it was confirmed in this adjuvant study presented. It was with atezolizumab, but KIM1 seems to be an interesting protein to detect minimal residual disease, to detect aggressiveness and increase in the disease burden. So it might be an interesting protein in the future to look at, not only in adjuvant setting, but also in metastatic setting. If it decreases, it probably means that the tumor is going better. If it increases, it's probably going to mean that the treatment is not very effective. So I guess that in the near future, we are going to use this protein more and more to try to better use our treatment in first line,
Right.
and better detect when we should switch to another treatment, when we have activity or not activity of a single treatment.
And you said that there's 4 lines of therapy. How would they discuss with their doctor about the choices that they have to make other than the one based on, "I want to be cured today"? How would you want these patients to discuss with you?
Or do they just say, "Professor Escudier, pick what you think I should get,
Should
and
get
then I'll
Yeah.
take that."
It's probably both. But honestly, the first question patients ask is, "Do you have a chance to be cured?" That's the first question they always
Yeah.
ask. And the second question they ask is, "How long do you think I'm going to survive?" Because they want to know, just to organize their life, what they expect, what they should do. The first question I always answer, yes, there is a chance to cure you, but the chance is not very high. But also the chance to cure you is not very high, in the range of 10% actually. The chance that you are going to live long, which means more than 5 years and maybe more than 10 years, is actually high. And that's what we have from the current therapy. And these numbers are actually improving every year. So I hope that when we go 4 years from now, hopefully, if you are not cured, we'll have improved our treatment and you will have more chance to live long. So that's always the first question they ask. And I never give any numbers in terms of exact numbers. I give usually a hope, especially when you start treatment, that if treatment is active, they can live more than 5 years. And that's actually what I say. And usually say, just remember that 20 years ago when I started to treat kidney cancer, the median survival was in the range of 1 year. It's more than 5 years. It's increasing every year. So I hope that you are going to benefit from this progress, and that's what I say to the patients.
Perfect.
And then
Thank you.
sorry, sorry, John. Do your patients then, the questions we asked you around biomarkers, do your patients actually engage into that conversation with you, or do you bring that up with them at all? They must say, "How do I know whether this drug will work on me or not?"
They almost, at least in France, they never ask about biomarkers. They ask me, what do I think should be the best treatment here, and do I have other options? And I usually explain what we have, that we have the choice between IO and IO-TKI, and that depending on the presentation of the disease, I have more insight to give IO than to give IO-TKI. And when we go to IO-TKI, I say why I prefer to select one regimen versus another one. And that's what the conversation is actually going on, knowing the fact that in my institution, a lot of patients are enrolled in clinical trials, because I usually say, we have this data and we want to improve the data. So we have ongoing studies, and if you accept to be part of it, you will have the standard treatment and maybe something else which will help us for the future patients to better know what we should do. But still, that's how the conversation is.
Can you elaborate more on Care One, that this major trial that you've started off in Europe, just so
Yeah.
the patients got a opportunity to understand what that means to the European
So
patient?
my belief is that if PDL1 is positive, that's probably patients with inflamed tumor and the patients where I want to give IO. And our expectation in this study is that in terms of survival, patients who receive IO when they are PDL1 positive are probably going to benefit more from treatment here. That's 25% of our patients we are PDL1 positive. If we are PDL1 negative, the benefit from IO is certainly less than it is in PDL1 positive. And our expectation in the study is that IO-TKI is probably going to be a little superior to IO combination. And that's what we are going to try to show in our study. And if it is, the good thing about that is that PD-L1 is easily accessible in every lab in the world. And it would help us, I mean, to at least to know who are the good patients for IO, which is nivolumab plus ipilimumab, versus those patients who are best candidate to receive IO-TKI. And that's, I think, is an important part of our job, is to go to answer this question of these different regimens, which are very different in terms of toxicity, in terms of second line, etc., etc.
And is this the phase 2 study or is it a phase 3?
No, it's a phase 3. More than 1,000 patients are going to be enrolled in many countries in Europe. I mean, we have started in France, Italy, Spain, Portugal, UK, Germany, Netherlands, Belgium are going to be part of the study.
That's great. So this could be, I mean, if positive, it could be practice changing and also,
I hope so. I hope so.
right?
Yeah,
And
yeah.
so from a regulatory component, it could have implications as well for patients on a positive way.
Sure, sure.
So on patient convenience in the first line, nivolumab has actually gone to sub-Q, and I know that there's a development program with pembrolizumab to go sub-Q. Do you believe it's going to make it easier for patients to receive their first-line therapy?
So I'm not absolutely a big fan of sub-Q. I think it's probably convenient for patients who live far away from the centers they receive treatment. A lot of patients do like to come every 2, 3, or 4 weeks to the hospital to see the doctors and to receive the infusion. So I don't think it's going to change a lot what we are going. I guess that sub-Q and IV are very equivalent in terms of efficacy, toxicity probably also, convenience. I mean, you still will have to have a nurse coming to give you the infusion sub-Q. So it's an probably interesting measure for some patients, but not for the majority of them.
Okay, thank you.
And, John and I have held previous episodes where we're specifically around liver cancer, because that's kind of our area of expertise per se. And we've always discussed the role of multidisciplinary teams within HCC treatment, liver cancer. I'm assuming it would be no different in terms of RCC treatment. Like, is this very apparent within your team, within your institution for MDTs to occur? And what does that look like? And if it doesn't, why not?
It is in my team. It is, I think, it's a big institution and the big academic centers. I'm not sure it is in all the centers in terms of management of this patient. Because one important thing is that when you have tumor reduction, which is what you get from many of these regimens, I mean, you get tumor shrinkage, you always have to think about, can we make patients free of disease by adding to medical treatment some additional techniques like stereotactic radiotherapy, surgery, radiofrequency ablation. So you need to have always in mind that if you can make a patient disease-free, you are probably going to improve the chance of survival and also improve the quality of life. So that's something that is very important. I'm sure that in big academic centers it's done. It's done in my institution. It might not be done in every institution, unfortunately.
Looking at the future, you mentioned that you've got TKI, combinations with immunotherapy. We've got immunotherapy combinations with immunotherapy. Where is the future going? Is it going to vaccines? How will it develop over time and step away from the TKI or the immunotherapy?
Two big steps in the treatment of kidney cancer. The first one was VEGF targeted agents, so TKI, which made the survival go from 1 year to 2 years. Then we have immunotherapy, which makes survival go from 2 years to 4 years, which is actually what we get. And we probably need a third big step. So this was the 2 big steps we had. Actually, I don't know which is going to be the third one. We honestly don't have the third one in the scope actually. Vaccine in kidney cancer is not actually what I would expect to be the next step, because we don't have good antigens to target actually, which is different from some tumors. But the antigen we have in kidney cancer are not very easy to target and are not very active in terms of vaccine. Is it going to be a new step that I don't know and that nobody knows? I don't think CAR T cell, as an example, is going to be a big change. It might be a little difference, but that's just a way to deliver a new therapy. Maybe working on microenvironment is going to do something important here. We had a lot in the past 2 years of data reported in terms of microbiota, of changing the way the immune system is going to respond to immunotherapy. And I think the question now is, can we make every tumor susceptible to respond to immunotherapy? I think at one point, that's only through immunotherapy that we're going to cure patients. And the way to render tumors which are refractory to immunotherapy sensitive to immunotherapy is going to be the next step for me. And there are some work ongoing, but not yet the one which I think is going to be the next step.
And as a follow-up to that question, I think it would be great for us to hear from you, because we were all at the ASCO meeting that happened this year. Were there any key presentations that you felt were compelling or practice changing, or was that not the case this year for kidney cancer?
Honestly, this was not a great for kidney cancer in terms of new data. I mean, we had interesting data, but I spoke about chemo1, I spoke about biomarkers, but nothing practice changing at that point. I hope ESMO in September will be more interesting in terms of kidney cancer. It was not a great kidney cancer ASCO. It has been great in terms of lung cancer, in terms of melanoma, breast, not kidney.
How would you summarize what we've just discussed today? How would you educate that patient to have a better conversation with his or her doctor about renal cell? Because the knowledge gap is quite large.
So I think the first conversation a patient should have with his doctor is, which kind of kidney cancer do I have? Is it clear cell? We spoke about clear cell mostly today. Or is it a non-clear cell, which is 25% of our patients? So that's the first conversation they should have, and just understand which type of kidney cancer they have. Most of them will have clear cell histology, but that's important to know. Second question they have to ask their doctors is, what is my group risk? Do I have a chance to live long, or do I have more chance to live very shortly? And I think it makes sense for a patient to ask this question, because the way you are going to handle your life, your personal life, your testimony, whatever, is certainly going to be important. Also, even if we say a patient, I mean, you are in the poor risk population, you might have chance to live long, but you have to know maybe, and you have to ask if your chance to live long is important or is low. And that's, for me, an important discussion they have to know. The third discussion they have to know is, most of these patients are asymptomatic, so they don't have any symptoms. They have a CT scan, and the radiologist say, I mean, oh my gosh, you have lung nodules, which are probably metastatic disease. And patients say, I mean, I have no symptoms. So what does it mean? And here they have to ask, I mean, do I have to start treatment immediately, or can I wait for this treatment? And that's a conversation they should have, and not be anxious if the doctor is answering. I mean, we can wait, we can do a next scan in 3 months and see how the disease is behaving. It will help us to select the best treatment here. And that's sometimes the best way to select the good treatment. If your metastases are not going to progress in 3 months, it means that it's a slow-growing disease, and the way you're going to handle the disease is not going to be the same. And finally, the questions they will ask probably is, if the first-line treatment fail, I mean, do I have some other treatment? And the doctor is probably going to answer, yes, we have different treatments, and we certainly will have other treatments which can be active, although the chance to cure you is mostly in first line, actually.
That was a lovely summary. Thank you. The 5 key bullet points. That was
I love it.
fantastic.
I love it. That
And
was
it was great. And sorry, you're right. We've only spoken about clear cell carcinoma on our episode today. I think, John, if you can give me a little bit of indulgence, can we have 2 or 3 minutes to talk about non-clear cell carcinoma, Professor? Is that okay?
It's okay for me.
yeah,
Um,
there's some exciting information there.
yes, because non-clear cell is again not my area of expertise, but it is a little bit more rare. So could you further elaborate? What are the current standards of care, treatment within the non-clear cell, and kind of where's the data today for non-clear cell carcinoma?
So when a patient is going to ask about non-clear cells, they have to know that the non-clear cell is still a large group of different tumors. There are two more important tumors in terms of numbers and incidence. One is papillary and one is chromophobe. So if you look at papillary, also once again, papillary is not homogeneous, but if you look at papillary, there is actually a consensus that the combination of IO and TKI is probably going to be the standard of care. It used to be TKI alone. It's now switching more in terms of combination of IO TKI, which is probably going to become the most important standard of care in papillary. So that's for papillary, which is a large group of non-clear cell. The second group is chromophobe, which is a little less frequent in terms of metastatic disease, but it's not an exceptional one. And in this group of disease, there was an interesting study at ASCO showing that combination seems to be more active than classical monotherapy that we had in the past. I guess that we have to look more carefully at this data because the chromophobe tumor is very different from clear cell and papillary in terms of sensitivity to immunotherapy. They are what we call cold tumors. They have very little inflammation and very little presence of infiltration of T cell. So actually, what we believe is that treatment of chromophobe might become a standard of care a combination, but more likely like a lavatinib everolimus combination. Lavatinib might be one of the most active drugs in the chromophobe tumors that we have in our hand, actually.
Sorry, when you said combination therapy, is it combinate versus monotherapy? Are you
Yeah,
talking IO TKI, IO?
that was a retrospective study showing that patients who receive combination had better outcomes than patients who receive monotherapy. But in fact, it's a combination. There was a mix between IO TKI and IO and TKI plus everolimus as an example. So we have to better define this group of patients because there are quite good consensus that IO is not very effective usually in chromophobe tumors.
In the chromophobe patients, there was some data from B61 study. It's going to be difficult for you to do a randomized phase 3 in that group because of the patient numbers. How does a patient ensure that they're going to get reimbursed if they should have to go on combination therapy? Is that an issue in France? Is it an issue that you would feel would be global?
This issue is going to be different from country to country because the reimbursement system is very different from one country to another one. In France, it's usually easy to have access to drugs. Once they are approved, the control is not very high, and we can use a regimen which are approved in clear cell, in non-clear cell. So actually, that's what we do. The big question is, are we right? And I disagree. I mean, we should be able to do a randomized study in chromophobe tumors. We have to find a way to do that. I gave you the example of the CARE1 studies that we are doing in Europe, which we are able to do. I think if we put all the forces together, we could be able to do a chromophobe study. The question is to find finances to support this study, and there are some European incentive to try to do pragmatic study, which really ask question about how to change the standard of care. And I hope that we'll have a chromophobe study in the future.
Oh, that'd be very exciting.
And I think, John, we've really had an amazing conversation with Professor Escudier. So thank you again. And before we officially close off, Professor, I'm going to ask you any key takeaways or some parting words that you wanted to share on this episode for the listeners out there with regards to kidney cancer.
Oh, I think my last comment would be kidney cancer is an amazing disease. I mean, we have been doing a lot of progress in the past 20 years. I mean, a lot of patients live for a long period of time with good quality of life. That's probably important that these patients go to good centers with experience and expertise in kidney cancer because it's not the most common disease. And if you go to someone who treat 1 or 2 kidney cancer a year, you are not going to have the same care that if you go to a site where they treat, like in our institution, 300 patients a year. So that's my big message and a big hope for patients. I mean, you can be cured, you can live longer even with a metastatic disease.
I love it. I love that. Right? Thank you.
Thank you.
Thank
Big
you.
hug.
Big
Thank you
venture
very,
hug.
very,
Thank you. John, as always, a pleasure, my friend. Thank you.
yeah. Professor Escudier, we're really indebted to you, and thank you for your time tonight.
Au
Bye-bye.
revoir. Au revoir.
Au revoir. MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.